This is a download from BFM 89.9, the business station.
Good afternoon and welcome to the show. I'm Mira Sevasodi. In our Health and Living segment today, we have Dr. Leong Ming Chern, a consultant pediatric cardiologist from Institute Jantung Negara. We're going to be discussing adult congenital heart disease and treatment options. He has a specific interest in that. Now, most of us when you hear about heart defects, it is quite common when babies are born. But most of the time, a lot of them go undetected. So Dr. Leong is in the studio to help us understand it a lot better. How are you today, Dr. Leong?
I'm fine, Mira. Thank you for having me.
Is all heart disease in children congenital? I mean, what do you consider congenital? When you say congenital heart disease, what do you actually mean?
Well, congenital means that if a baby is born, it already has the heart defect. So in children, we have three types of heart defects. Number one is the congenital heart defects, which means the babies are born with the defects. The other ones are the acquired ones. So usually babies are born well, but over time they contract diseases that causes inflammation of the heart structures, which damages the heart structures. The third main group is the heart arrhythmia. So they have abnormal heart rhythm that causes them to have fainting spells, palpitation, and these are the three groups.
Okay. Is it true that, they say when a baby is actually in the mother's womb and as soon as they come out, because when they're breathing in the womb, it's a very different process to after they come out. After they come out, your valves shut, everything has to, the child has to start breathing on its own now, right? What actually happens? And then that's where a lot of congenital heart defects also come from. Could you explain that to me, please?
Well, actually, congenital heart defects actually occurs much earlier. So when the baby's in the mother's womb, the heart starts to form. It starts to form at about 5 weeks and completes at about 20-something weeks. So what happens is there is some disruption in the formation of the heart, which causes the heart to have defects. For example, you have disruption of formation of the wall of the heart, and that gives rise to a hole in the heart, for example. Sometimes it gives rise to formation of blood vessels. That's why the blood vessels are either transposed or they are stenosed. And so
when you are in the womb, you're not breathing air.
Right.
So valves are all open, am I correct?
Yes.
Then as soon as you come out and you start breathing, they shut. Right. And sometimes some of them don't shut.
Right.
Is that what contributes towards some of the heart defects as well?
Not really. So what happens is as soon as the baby starts to breathe by themselves, there are some physiological changes to the heart. And most of the time, baby can undergo these physiological changes very well. There are some babies who don't undergo this transition very well. Then they go into trouble. But usually it has something to do with the lungs rather than the heart.
Okay. So what you're saying is most of them, most congenital heart defects are already happening between the ages of 5 weeks and the 20+ weeks.
Yes, that's right.
Okay. Mm-hmm. Could you tell us a little bit more about adult congenital heart disease?
Well, so adult congenital heart disease is very close to my heart. It's my special interest is in adult congenital heart disease. So it's basically congenital heart disease that occurs in adults. We have two main groups of patients that comes into this picture. The first group is the ones that are detected early during childhood. They are being treated, and because of the treatment, they survive till adulthood. But this doesn't mean that they don't need any more follow-ups. They may have a complication in the future. They may want to get pregnant. The ONG specialist might want to know whether they can get pregnant. They want to get involved in some occupation. We just need to find out whether their heart can cope with this kind of stress. So we follow them up and make sure they're in the best of health. The second group is actually the group that was missed. This group of patients, they may have some mild heart defects who maybe get picked up during a medical checkup or when they apply for university, they had a chest x-ray done and they found that the chest x-ray looks a bit funny. That's why they were referred to us for further workup.
Okay, and what do you do when they come to you? And what's the percentage between the ones that have been detected early and the one that, often they're missed, actually? In fact, some people die with a hole in the heart without even knowing that they had it their entire life.
Right, I would think that in this in this current era, so I would say that it's very rare for people to die from congenital heart disease without knowing it. But it was not uncommon like 30, 40 years ago. I would say that 60 to 70% of my patients are actually graduates from the pediatric side. 30 to 40% are from newly diagnosed adults with congenital heart disease.
Okay. So what I'm saying is they don't die of a heart disease, they die with the congenital defect. Meaning it goes completely, they never ever knew they had a heart condition because it was so mild that they managed to lead a normal life and eventually just, die of old age.
So the mild ones, they don't die from the milder ones.
Yeah.
Yeah, but they have affected quality of life, for example. They because they have been born with this hole in the heart, for example. Although they are mild, they have decrease in effort tolerance, but they don't know that they have decrease in effort tolerance because they don't know what's normal.
What do you mean by effort tolerance?
Effort tolerance means they have decreased ability to exert themselves. Like, for example, the normal people can scale more than 2 flights of stairs. They may not be able to scale more than 2 flights of stairs. Maybe they may think that they have poorer health, or because of obesities, or because they don't exercise that much, that's why they have poorer effort tolerance. But in real fact, they may have a congenital heart disease that was missed previously.
How do you measure this effort tolerance?
We have subjective and objective measurements. Subjective means we ask them on a good day, how many flights of stairs can I climb? If they say I can climb 3 or 4 flights of stairs, it's fine. If they can't even climb stairs, that's worrying. Some people may even tell you that I feel it when I walk on a flat, but I can feel it there's a slight slope. So these are people who are very sensitive towards increase in effort tolerance. So we know somewhat that they actually have subnormal effort tolerance. The objective measurements, we have tools to measure the effort tolerance. We have like stress tests, we have oxygen cardiopulmonary testing that we can actually stress the patients on a treadmill and find out how far they can go.
Who is actually at risk of a congenital heart defect?
People who have syndromes, they have a high risk of getting congenital heart disease. For example, people with Down syndrome, they have a 50 to 60% of risk of getting congenital heart disease. We know that if a mother takes alcohol, smoke, or takes recreational drugs, they're at a high risk of getting congenital heart disease. And mothers, if they are not vaccinated against rubella, they get rubella during pregnancy, they're at a high risk of getting pregnancy. But unfortunately, most of the patients, they do not have these risk factors because about 1% of children born will have congenital heart disease. It's like you have a factory producing boxes. 1% will have defects. Mm-hmm. That's how we get our congenital heart disease.
Okay, so what are the best ways? I mean, and how has Malaysia improved over the years in terms of our approach to managing congenital heart disease?
Well, we have improved quite a lot. In fact, at IJN, we are world-renowned for treating patients with congenital heart disease. We have the latest technology, the know-how, the manpower. But importantly, it's not about treating them, it's about detecting them early. So we from the Malaysian Pediatric Cardiac Society, we work with the Ministry of Health, and we actually came up with a screening program. So screening program doesn't mean that we scan all newborn babies with a heart scan machine, echocardiography. Basically, what we do is we have a baby check straight after they're born to make sure that there's no heart murmur, and also we check the oxygen saturation, the oxygen content of the body, to make sure that it's 100% before we discharge them home.
Okay, and that should be the standard operating practice, I suppose.
Yes, that's
when a child is born, whether government or private, it's always done.
That's right.
Let's talk about murmurs. A lot of children are told that they have a murmur. What is a murmur actually? And are they always dangerous?
Murmur are basically sounds created by turbulent blood flow. As the blood flows through the heart structures, if there's a narrowing, there's a hole in the heart, the blood will go turbulent, and we have a sound what we call murmur. So if you were to open a tap, at the tap you just try to squeeze the blood, try to prevent water from coming out. Mm-hmm. You have this gushing of water sound. That is what we call it murmur in cardiology practice. So murmur basically just means sound. So it can be something which is alarming to suggest a congenital heart disease, for example, a hole in the heart. Or it can be that the heart is being super active. After the child runs, the heart pumps stronger and faster. That's why you get a little bit of turbulence in the blood flow. It doesn't mean that the child definitely has a congenital heart disease, but it may suggest so.
And it's quite amazing because just, as pediatric cardiologists, you just have to put a stethoscope to the child's chest and you can actually tell what sort of congenital heart defect that is. I think that's quite amazing.
Yeah.
How do you tell from the different sounds of the murmur?
Yeah, we can time the murmur to tell us where the murmur comes from. It may suggest whether it comes from the valves, from the wall of the heart, or it's because of the narrow blood vessels. But in order to get the correct diagnosis, we still have to scan the child.
Okay, which is to do
a heart scan or echocardiography.
An echo.
Yes,
okay,
that's
all right.
right.
And there are different types of congenital heart diseases. Do you just want to go through that with me?
Yes, please. There are two main types of congenital heart disease. The acyanotic ones, which means that the baby is born pink, and the cyanotic ones, the babies are born blue. So the acyanotic ones, a good example of it is, for example, a hole in the heart, ventricular septal defect. It basically means there's a hole in the pumping, the wall that separates the two pumping chambers. And what happens is, if you have a hole in the pumping chambers, there will be additional flow to the lungs. So this additional flow to the lungs may be 2 or 3 times or even 4 times higher than the normal. So you can imagine that our lungs is like a sponge that you use to wash your car with. When it's dry, it's very light. Mm-hmm. When it's wet, it's very heavy. And you can imagine if a small child tries to expand heavy lungs they have, they need to exert more energy. They need to have increased work of breathing. They don't feed that well. They don't breathe that well, and then don't grow that well. So these are the ones that we need to intervene. On the other extreme, if a child has very little flow to the lungs, they'll be very, very blue. So these group of patients will be hypoxic, which means they are lack in oxygen. Mm-hmm. And this group of babies cannot exert themselves. They can go to school, they can carry their school bag to go to the classroom upstairs, and etc. Again, these are the groups that we try to help them.
Okay. And symptoms would just be, I suppose for the blue babies, you can actually tell something's wrong, but with the pink babies, you probably can't.
We can tell as well. So if the pink babies with congenital heart disease, there's a wide spectrum to it. The milder ones, they obviously have no symptoms at all. The severe ones, they have shortness of breath. They don't grow that well. They have recurrent chest infections to suggest that they actually may have a congenital heart disease. So we do detect them quite early, especially when they come for immunization. You find that the child doesn't grow that well, then it rings a bell.
And the red flags already.
Yes, that's
okay.
right.
All right. We're discussing congenital heart disease and treatment options with Dr. Leong Ming Chern, a consultant pediatric cardiologist from IJN. When we come back, we'll find out more about some of the causes and whether or not awareness about child heart disease is enough in Malaysia on The Bigger Picture, BFM 89.9. Good afternoon and welcome to the show. I am Mira Sevasodi, Dr. Leong Ming Chern, consultant pediatric cardiologist in the studio with us from Institute Jantung Negara. We are discussing congenital heart disease and treatment options. I think Dr. Leong has gone through with us that there are 3 types of congenital heart disease. You have congenital, you have acquired and heart arrhythmia. You've gone through all of that. You've also spoken to us about adult congenital heart disease, whereby adults who, people who grow into adults who have had a congenital heart defect and, maintain their life in adulthood. And those, of course, who have been missed as adults to have had a congenital heart defect. And as you said, 1% of children will have a congenital heart defect. So I suppose it's something that we will have to deal with anyway. Do you think awareness is enough in Malaysia? Do you think we understand this topic enough?
Well, we thought we know enough about congenital heart disease, but to the parents, a lot of times I find them being shocked when we tell them the diagnosis that the child has a congenital heart disease. They thought that this would only occur in underprivileged children. They're not well looked after. That's why they have congenital heart disease. But this is not true, because 1% of the children born will have congenital heart disease, and it can occur in anyone at all. So awareness is very important. We should educate mothers, and we need to educate the doctors as well. If you feel suspicious about this child, send them over. We'll work the patient up.
How do you deal with the parents, though? I mean, they're proud parents, and after that, you tell them the child has a congenital heart defect. I can tell you the first thing that runs through your head, it's doom and gloom, because it's the heart. And you always imagine the worst because it's the heart.
Yes, that's right.
How do you speak to them and make them understand?
Well, actually, we need a couple of sessions before we can get things through. So the first time you announce the bad news to the parents, a lot of them will go blank. They will just listen to the things that they want to hear, and they will filter out the things that don't want to hear. So they will know that the child has congenital heart disease. They know probably what we're going to do next. Well, and that's it. Whether the risk involved and whether the patient needs repeated surgeries, they'll probably filter that out. So usually we take a few sessions, and I think the important thing is to support them through, try to be empathic, and know that it's quite hard for them, because I find that some of the juniors doctors, they don't understand how come the parents are so
devastated,
or some of the parents don't even realize the severity of the heart disease, despite explaining to them once or twice. And I just feel that we just need to be patient with the parents, need to support them through. It's very, very important.
Can most congenital heart diseases be fixed?
I would say 70% of the congenital heart disease can be fixed. Some congenital heart disease is too complex. We cannot fix them. We can palliate them, but not fix them, which means that we can improve the quality of life, but unfortunately, we cannot cure them.
Okay. And diagnosis methods would be what? Just an echocardiogram, or the first thing is for you to listen with a stethoscope and then take it from there? Is that what happens?
So the diagnosis starts from taking a good history, examine the child, doing the ECG, X-ray.
When they're born, or?
Yes, when they're born. Doing ECG, X-ray, and echocardiography. But now we have newer tools to allow us to understand heart even more. We have CT scans, we have MRIs, we have cardiac catheterization that allows us to understand heart a bit more, so that we can plan out which is the best treatment modality for the child. And
should all newborns, in your opinion, should be screened?
I would say yes, all newborns should be screened.
And what do you mean by screen?
Right. I mentioned a while ago that all newborn babies will undergo a thorough baby screening, a thorough baby check, which means we check the brain, we check the lungs, we check the tummies, and we listen out for murmurs. And at the same time, we check the oxygen saturation of the child. If the oxygen saturation is not 100%, we will evaluate the patient further by doing ECG, X-rays, or even echocardiography.
I'm sure at IJN you've seen a ton of, or dealt with a ton of congenital heart disease.
Yes.
Have you got any special way, or based on experience, have you sort of streamlined, or, it's sort of like, second nature for you now,
right.
dealing with these conditions, isn't it?
Yes.
Has much changed in how you tackle each case?
Yes. We find that we used to have problems with complex cases. We used to find that the heart structures is too complex, it's very difficult to understand. But with newer tools, newer imaging modalities, we find that we are getting more and more accurate diagnosis, and in a non-invasive ways. And this is very good for the patient, because we get accurate diagnosis before we can plan out which is the best treatment option, which is the safest and the best treatment options for the child. And we do have a registry that tells us which patients will do well and which patients will not do well, instead of operating blindly on patients, not knowing that they have poor prognosis. And those with poor prognosis, I feel that they are best given love and care rather than subjecting them for surgery.
Surgery, okay. And all of this, and what are they a very small percentage?
Yeah, only very small percentage.
Because you said 30% will need intervention. Of that 30%, it's even smaller?
Yes, that's right.
Okay. How many of these cases, the patients that you see, how would you describe them, the 1% across the population?
Right.
But is there have you come up with a demographic of this 1%? Are there any common threads in the 1% that you see?
Unfortunately, we do not have a common trend. You see that the 1% out of every newborn is not unique to only Malaysia. You do see that in America, in Africa, in Europe, we don't have the same the diet, we don't have the same genes, but we still have the same prevalence, 1 in 100. So we up till now we cannot pinpoint what's wrong with the heart and what causes increased risk of getting congenital heart disease.
It's just going to happen.
It's just
going
by
to
chance.
happen.
By chance.
Okay. And what's the ideal time to actually intervene if intervention is required?
Right. So we always think very hard before intervening, because number one, we don't want to subject a child for unnecessary surgery, because every surgery or every intervention carries risk. And then we always question our intervention. Is it the correct intervention? Is it necessary? Are we subjecting harm to the patient, or are we subjecting the patient for or something good? So the best way to gauge the timing of surgery is, if we don't do surgery, will the patient get worse? That's the question you always ask. So we will always ask these questions before we decide for surgery. Sometimes it's a very grey area.
It is, because they're tiny, they're fragile.
Yes.
To take on surgery at that age. So
Yes.
I'm assuming that you would, if you can delay it, if surgery is required, you would. Ideally.
Yes, ideally. But at the same time, we don't want to be too far gone. We don't want the child to miss the boat. So I would say that if the patient's symptomatic, we will intervene. Those who are without symptoms, we will watch and see. If the time comes, the heart shows signs that it's struggling, we may need to go in before the child starts to have signs.
What do you mean by miss the boat?
Right. For example, if a child has a hole in the heart, right? So what happens is you have additional flow to the lungs. So what it does is it will damage the lungs in the long run, right? So it will go into the state what we call a pulmonary hypertension, whereby the lungs get severely damaged beyond repair, that even if you close the lesion, it may be too late for the child. The child still have a lower life expectancy.
When you say hole in the heart, everybody
Yes.
says hole in the heart.
Right.
For those of us who don't really understand
Right.
what a hole in the heart, you just imagine a real hole.
Mm-hmm.
But what do you mean when you say a hole in the heart?
All right. So like our arms, our heart actually has two components, the right component and the left component. So if you have a hole in the heart, when we're talking about the septum, or the wall that separates the two components of the heart, the right and from the left. So this hole in the heart actually prevents mixing of blood. So if there's a hole in the heart, it will allow mixing, allows blood from one chamber to go to the other chamber and get pumped to the lungs, for example. And it will cause increased flow to the lungs. Over the long run, it will destroy the lungs in the long run.
Okay, so that's what you mean by
Yes.
the gap. It's actually a
Yes,
gap in the
that's right.
wall.
That's right.
We literally think of a hole with,
Yes, a defect, I would say.
Yes, exactly. How well, you said 70% may not need intervention.
I would say 50, sorry.
50% will not,
doesn't need intervention.
don't need intervention. And will they lead a normal life?
Yes, they need a normal life. They, the ones with milder disease, they actually have normal effort tolerance. They can participate in school activities. They can scale for example, Mau Kinabalu, or they can take up normal jobs. Can undergo pregnancy during adulthood. There's no difference in effort tolerance for the milder ones, of course, compared to any other normal human beings, normal people without heart disease.
So you're saying they can function without surgery?
Yes, they can function without surgeries for the milder ones.
Isn't that a risk, though? Because if you do push yourself, and it is an exertion on the heart, it can be detrimental.
I wouldn't say no. I don't think so.
It's not.
Yeah, it's not. So if the hole is small, for example, the hole is 2 to 3 millimeters, actually subjecting a child with such a small hole for surgery is actually may cause more harm, because the risk of surgery is higher than not doing anything at all.
Okay.
But if complication sets in, but we have no choice but to intervene.
So with somebody with a very small hole, as you said, no need for intervention. What about the time when somebody decides to get pregnant, though? If it's a woman and she does have a hole in the heart, which, does not need intervention, will that affect pregnancy, for an example?
No, she can undergo pregnancy normally, she can deliver normally, and we wouldn't stop her from getting pregnant.
How would a hole in the heart affect a woman who's pregnant?
All right. So what happens in during pregnancy is that you have volume expansion, because not only does the heart need to pump to the mother, the heart needs to pump blood to the babies as well. So there will be expansion of blood volume, there will be additional volume, and imagine every time the heart pumps, the additional blood volume will go to the lungs. So the lungs will be even more wet, so the mother will feel a little bit more breathless. But if the hole in the heart is small, the amount of blood that gushes through into the lungs are very little, perhaps an additional 5% increase in the lung wetness. So this doesn't cause much problems to the mother.
Okay, so very obvious that the heart and the lung work very much together.
Close to each other. Yeah.
Very close to each other. In some of these interventions, do they require follow-up or maybe further surgeries later on in life?
Right. For the simple ones, the surgery is just one off and that's it. For the moderate and the complex heart lesions, they may need more than one surgery, unfortunately. And many of them, especially those with complex heart disease, even after surgeries, they need lifelong follow-up, because they may have complications down the road, 30, 40 years later, and they may have new needs. For example, if you want to apply for jobs, want to get pregnant, they might need to a doctor to certify that the heart is strong enough to undergo these activities.
Okay, and can we actually prevent? After all this time, we know 1% of the children will have a hole in or a heart defect. Can we prevent it?
Well, although we do know that we cannot do much to prevent it, but still we can still do something to prevent congenital heart disease. We know that having rubella infection during pregnancy will increase the risk of getting congenital heart disease. Having uncontrolled diabetes will increase the risk of congenital heart disease. And drinking alcohol, smoking, taking recreational drugs will increase the risk of getting congenital heart disease. If you avoid all these, get your diabetes well controlled, adhere to the diet restriction and all that, make sure that ladies get rubella vaccination before pregnancies, we can, to some extent, prevent congenital heart disease.
So, as you mentioned earlier, the heart is forming from 5 weeks to 20 over weeks, right?
Mm-hmm.
Is there a way of monitoring the baby's heart? And if you do know that there is something that's not normal, can you intervene at that stage?
All right. We are able to scan the baby, even the mother's pregnant, still pregnant. So we usually scan the babies at about 18 to 22 weeks. And if we find something which is abnormal, we won't be able to intervene at that time because the baby is too fragile for intervention. So what we can do is we can counsel the parents, we can preempt the parents what they're going to expect, and if they are from far away from KL or from IJN, for example, we would ask them to come over and perhaps get themselves delivered somewhere nearby. And once the baby is delivered, we'll give them instructions. This is what you're going to do. You're going to ask the doctor to start this medication. We'll liaise with the local hospital to start this medication, sent to IJN, so you intervene early. Instead of them going home and then deteriorate a couple of months later after delivery, and then present to IJN at a very sick stage. This is what we can do. This is what we call a fetal scan. It is available in Malaysia, in IJN, in another private hospital in KL, and in Penang and in JB. This is something which is available.
Okay. And what do you think in terms of healthcare access, we have it for these children with congenital heart disease? And in terms of cost, do you think that's a challenge to fix some of these defects as well?
Access-wise, I do not think that's a problem. As long as all Malaysian are welcome to IJN and get their heart checked. For non-Malaysians, it's a bit tricky because we don't have welfare fund that covers for foreigners, and this is where they have to pay their own cost of treatment. And we know that this treatment is very expensive, and the care is very intensive. The cost is very high, and it may not be readily available to like foreigners, for example.
Are you excited about any research or development that's coming up in this area?
Well, we find that the cardiology has improved for the past 10 years more than it has been for the past 50 years. Because with newer technology, we can access to places that we wouldn't be able to do. And then imaging modality allows us to diagnose patients more accurately. The pictures are more real compared to the previous pictures, which is black and white. And then we can even create a 3D model of the heart and then plan out our surgeries and then actually do some hypothesis and try option A, it doesn't work, and then try on another model with options B before we actually operate on the child.
So like 3D printing?
3D printing, exactly.
Okay.
Yeah, we can actually print out a soft plastic model and actually test on a plastic model before we actually operate on the child.
Operate on the child. So you go in, minimal time.
Yes, minimal time.
Know exactly what you're going to do.
Yes, and we know that we have a high success rate and a better outcome this way.
Okay. And are you excited about anything in particular? I mean, 3D printing might be one. Are you already doing that in IJN?
We are thinking of starting our own 3D printing. Right now, there are commercially some companies outside that are willing to do it at a fee. But it's just that the fees is very expensive. It's we won't be able to extend it to everyone, only the complex cases. But we're toying the idea of having our own in-house 3D printing facilities.
But time is of essence. Do you have time to experiment on 3D and then go in and intervene as far as the child is concerned? Or is experimenting on 3D printing quick and far outweighs the risks involved?
I would say it far outweighs. It's better to experiment on a model than a child. And that's... You can't value life. Life is very valuable. It's better to, although it takes up more time, but there's no value. You cannot compare it with life.
How do you do it, Dr. Leong? I mean, a child's heart is tiny.
Right.
It's absolutely tiny. How do you operate on a child?
Well, we have what we call a loop. Actually, it's a magnifying glass that will magnify the heart structures 2 or 3 times when we operate on the child. And it's a matter of getting used to, I would say.
Okay, you must have super eyesight then.
No, surgeons have super eyesight.
Yes, of course. You're the cardiologist, I forgot. You don't get your hands dirty, do you?
We do. We do the cardiac catheterization, we do the keyhole transcatheter intervention, we do the imaging part. We work closely with surgeons and tell them these are the problems, whether you can fix it, how confident are you in fixing this? Do you need a model before you fix the heart and all that?
So you work very closely with the surgeons?
Yes.
Okay.
We all work very closely as a team.
As a team. Who's involved? Yourself?
The intensivists. We have intensivists that looks after intensive care, the cardiologist that makes the diagnosis and imaging. We have the surgeons who operates on the child. We have the anesthetist who's specializing in anesthetizing small babies.
Which is a very different thing altogether.
Very different thing altogether, yes.
Okay, and risks involved as well.
Yes.
As would anyone going under anesthesia, I suppose. Right. Okay. Would you have a message for us on congenital heart disease?
I would say that one of our challenges is cost for the treatment. So basically, the very poor, they qualify for financial aid, full financial aid. In fact, the very rich will have no problems paying for the cost of treatment. But the middle class will suffer. So what happens is they're not poor enough to qualify for full financial aid, but they cannot afford the full fees of it. So what we're trying to do is that we have already established this IJN Foundation. And this IJN Foundation does a lot of fundraising activities to get money to help them pay for the fees and for the medical care. So what happens is we need the public to help out, to support this foundation. And I would urge people to, rather than donate to individuals, why don't you just donate it to this foundation? Because the leftover money will carry forward and be used on subsequent patients rather than benefiting a particular individual.
Okay, and that's for the middle class that you're concerned about. In
fact, that constitute most of our patients.
Yeah, I can imagine.
Yes.
Yeah. Okay. So the IJN Foundation is where you should go and donate if you'd like to help children with a congenital heart defect or disease who come through the IJN doors. Thank you very much for joining us today. That
Thank you
was
very much.
Dr. Leong Ming Chern, consultant pediatric cardiologist from Institute Jantung Negara, speaking to us about congenital heart disease on the Bigger Picture, BFM 89.9.